First of all, thanks to organization. I am breast surgeon, oncosurgeon, not radiation oncology. But because we began from 2 years ago, September 2013, to work with the IORT machine, we've found some trials around the world to know how is work and what is the result with this machine. As my professor told you, the intraoperative radiotherapy has the same philosophy with the external beam radiation. But we can give the patient the radiation to well-vascularized margin of the cancer that may be some microscopic tumor cell are where, and we can damage these cancer cells. The first experience was 1905 with the case of the endometrial cancer, and after that, Professor Abe was the first person who sent the patient to the radiation department to do the radiation in the abdomen for the gastric cancer. As you see, these are the transportation of the patient. And then the machine comes to the operating room, but it was not mobile. And then the two mobiles device is created and come to the operating room for give the patient the radiation. And then two big trial. The first one was Elliot that done by the Institute of Oncology in the Milan by Professor Veronesi from 2000. And they used the electron beam radiation. And another one was the Target A, was a project that is done in 11 countries in 33 centers that they began again in 2000. But they used the X-ray, not the electron. As the result in the local recurrence was so different, we wanted to have a trial to find what is the reason for this difference in the local recurrence. So at the first, I have to begin with these two trials and talk about the trial. As I told you, in the Elliot, they used the electron beam, and they used some cylinders that you saw them in my before me, in my colleagues' articles, and the energy is 4 to 12 MeV, but in the target 50 kV, the time is so different. In the electron, it need only 3 to 5 minutes, but in the X-ray, you need more than 30 minutes. And something is different because in the X-ray, only in the 1 centimeter around the tumor, you have 20 gray energy. And after it, the energy is decreased to only 5 to 7 gray. These are two machines. And this is how to do. In the target, we use some cylinders. They are between 1.5 centimeter to 5 centimeter, and we have to pierce the tissue around it. And as I told you, only in 1 centimeter, we have 12 gray, 20 gray, and after that, it decreases only to 5 gray. But in the electron, when we use this cylinder, all part of this cylinder, we can choose the cylinder between 4, 3, up to 10. But in the Elliot project, they use between 4 to 8 centimeters. Okay, if you have a look to these two projects, the older age was more in the target, and in the Elliot, the old age was less. The tumor, the small tumor, was more in the target and less in the Elliot. It means the bigger size was chosen for the radical IORT in the Elliot project. And you see the grade 1, again, is more in the target, and the grade 3 is more in the Elliot. It means some unfavorable characteristics are more in the Elliot project. You see, the lobular carcinoma was only 4% in the target in the X-ray, and they gave the patient external beam radiation after the operation. But in the IORT, with the electron, in the Elliot, in the IEO of the Milan, they had 8% invasive lobular carcinoma, and they didn't give any external beam radiation after the operation to the patient. And you see the positive lymph nodes. All of you know the positive lymph node is the contraindication for the patient. The patient needs the external beam, and it's contraindication for putting the patient in one session in the operating room to do a partial breast radiation in the breast. The patient needs to give the radiation to the axilla. And you see in the Elliott project, they had 21% that had a positive lymph node between 1 to 3 and 5% more than 3. In the target, all of the patients who had positive lymph node gave the external beam after the IURT. So, the age, as I told you, and the tumor size and the grade 3 histology and lymph node, all of the unfavorable characteristics are more in the Elliott, and the favorable characteristics are more in target A. According to the result of these two trials, the endocrine therapy, chemotherapy, and other adjuvant therapy are the same in both projects. And you see, as I told you, the unbelievable percent, 4.4% in the IORT group of Elliott project had local recurrence. And then I will show you the calculation was little problematic. And in this project, 3.3. In the Elliott, the tumor size more than 2 centimeters was unfavorable, and in target A, only 1 centimeter. Positive lymph node, all of the positive lymph node in the target choose as the unfavorable characteristic, but in the Elliott, till to 4 lymph node positive was not included in the patient who need the external beam radiation. The grade 3, like each other, the negative estrogen receptor and triple negative was unfavorable characteristic. Please have a look to these, all of 2 centimeter, more than 5 positive lymph node, grade 3, and these triple negative patient that I will show you the difference between the local recurrence of this group and another group. You see, in the Elliott project, the local recurrence is different, 4% for the internal radiation and only 0.4 for the external. In the target A, they had 2 groups, pre-pathologic, it means the patient who take the IORT at the same time in first operation, and post-pathology, some of the patient is closed in the operating room, and before 1 month, it means between 0 to 30 days, they open the patient again and give the patient intraoperative radiotherapy. And this is the difference in the target that you see in the pre-pathologic, the difference in the local recurrence, in the external and internal radiation was very less, and in the post-pathologic group, it means the patient who take the intraoperative radiotherapy in another operating. If you have a look to the all trial around the world, you can see the local recurrence rate is between 2.8 to 6.7 for lymph node negative and 11% in lymph node negative, in lymph node positive patient. This is the rate. So the 4% is not very large amount of the local recurrence. It is the same as all around the external beam radiotherapy trial around the world. This is very important. In the 2 studies, if you can see to the survival rate in the Elliott, there was no any difference in the survival between the internal and external radiation. But in the target A, they could show that the external beam radiation have more non-breast cancer deaths. This is due to the heart or lung disease after the operation. This is the breast cancer death in target, and this is the non-breast cancer death in the target group. But in the Elliott, they didn't have any difference between these two. So as the recurrence rate, local recurrence rate in the Elliott was so big, the European Society of Radiation Oncology take the database of the Elliott project and analyze it again. Then they divided the patient to 3 groups: the good person who did the radiation intraoperative, the possible group, and the contraindicated group. Then the rate of the local recurrence was changed. You see only 1.6% of the patient who had good characteristics had local recurrence. And in the contraindicated group that I will show who is contraindicated, they had a lot of the local recurrence rate, 707. 707. And then the ASTRO, the American Society of Radiation Oncologists, they created a consensus and they give us a guideline and they analyze this database. And then they told that the suitable group that was less than 1/3 of the patient in the Elliott study had only 1.5% of local recurrence, and the patient was not suitable, that was 44% of the patient in this study. They were not suitable for taking the only intraoperative radiation, and you see the local recurrence was more than 8%. And this is according to ASTRO guideline. This is the patient who was not who was unsuitable, less than 50 years old, the tumor more than 3 centimeter, margin positive, extensive lymphovascular invasion, and any positive lymph nodes. These patients need to give external beam radiation, and the intraoperative is not enough for them. But the suitable cases was older patient with tumor size less than 2 centimeter, negative margin, no any lymphovascular invasion, N0, and unifocal tumor. So old age, tumor less. These are the favorable characteristics in the target A versus the Elliott. You see the old age, tumor less than 1 centimeter, the only ductal carcinoma, invasive, negative lymph node, and less positive lymph node. And this is the end. If you divided the patient of the Elliott into suitable and unsuitable group, you can find that only 1.5% local recurrence in the Elliott, in the electron, and more than this in 2.1% in the target group with using the X-ray group. So if they change the analysis of the database, you can find this result in these two trials. Thank you.